consistent with the presented data before. So the take-home messages are: the anatomical outcome of pelvic organ surgery in the elderly is comparable to that in younger patients. Older women may be at a little bit higher risk for de novo stress incontinence after prolapse surgery. Older women have higher post-operative complications, but those serious complications remain rare and are comparable to the number in younger patients. And in advising our patients, surgery should not be avoided based on age alone. The choice of the procedure should address the patient-specific disorder and problems, and reconstructive surgery should be the first line, not the obliterative surgery that should be preserved for patients with very high preoperative comorbidity. As for stress urinary incontinence, cure rates of the older women seem a little bit less, ranging about 45 to 90% compared with younger patients. And still, older women undergoing incontinence surgery can expect continence rates that are favorable too. Incontinence surgery in this old population has a high risk for complications, mainly urinary tract infections and voiding dysfunctions, but serious or life-threatening complications still are comparably low. And the choice of the surgery depends on surgeon's experience as well as the specific patient's history. And before I reach the end of this lecture, I would like to ask the last why. And I'm very happy that I came here to Egypt because before I came, I thought Egypt was the mother of all civilizations. And why was it good that I came here? Because I have learned through my Egyptian colleagues that actually Egypt is the mother of the world. So thank you for your attention.
Yes, thank you very much. We have plenty of time for discussion, and therefore you should use the opportunity to put those questions which you want to put. We will start with your presentations. Do you have any questions concerning urogynecology? What is your opinion about the treatment of elderly? Yes, the first question in front. Can you please repeat the question?
I think Professor Ramsey asked about the usage of laser therapy in case of stress urinary incontinence. Am I right? Well, there are very promising future therapies regarding stem cell therapies and trying to do something about the tissue that is suburethral, and there are some efforts being about using laser, but the data are still very few, and this might be an option in the future. But actually nowadays, mainly the treatment of stress urinary incontinence is still performed using the Birch procedure, the colposuspension, either through open laparotomy or mini laparotomy or laparoscopically, and using the suburethral slings in their many different forms. For special cases, for special patients like those having partial urethral resection, for oncological diseases, and preserved for some other patients, we can use bulking agents too. And for those refractory to all kinds of these treatments, there is the artificial sphincter, urethral sphincter, that can be applied. And this technique is still performed per open technique, but I think in the near future we will present it laparoscopically too. All the other therapies you mentioned, maybe something we see in the future to come. Thank you very much.
Okay, thank you. Yes, your question.
Now, welcome, Professor. My question is, if you have a patient with recurrent stress incontinence after TVT, what do you think could be the management of this patient, early surgery?
Thank you very much for this question. This is this may be a simple question, but it isn't actually, because first of all, we perform a kind of error finding. That means we will see why this TVT doesn't work. Main procedure you have to perform would be performing pelvic floor sonography at first, so to identify what the risk factors for this patient had been that this TVT doesn't work. In some cases, if you realize that the problem is with the technique rather than with the procedure itself, you can remove the central part of this TVT so that the suburethral part is free again and totally mobile, and you can choose to apply a second suburethral sling, and there are some data about that. You may choose to take the same route you chose for the first time. That means you can even repeat a retropubic suburethral sling, or you choose the transobturator. In cases where you don't think that the problem is with the technique, rather by choosing the procedure itself or by anatomical problems, you may need to perform the Birch colpal suspension in this patient. Thank you very much.
Yeah, the next question.
I am Dr. Sharkawi for Cairo University, professor at Cairo University. I want to ask you about your opinion in a case of failure of medical treatment in neurogenic bladder, in detrosal instability, failure of medical treatment. What is the role of the Botox injection in the bladder? It is effective or it is not?
So
In
you're
your-
asking me about Botox for
Yes.
the overactive bladder?
Yes, exactly.
Yes. Actually, when you fail to find a central neurogenic pathology, that means you haven't got a patient with multiple sclerosis or other central neurologic disease causing that, then Botox in most cases is rather effective. You have to identify some cases of patients having problem with the peripheral nervous system. In those cases, it's sometimes more favorable outcome if you perform a sacral nerve stimulation, because in those patients with a sacral nerve stimulation, you have a very long effort, a very long success in treatment that may last for 5 to 8 years. The problem with the Botox would be that you will have to repeat this injection
Every
sometime.
6 months or every year?
Excuse me?
You have to repeat every 6 months or every year? The
It
injection.
depends on some metabolic issues in each patient, but in the medium it takes 9 to 10 months, and then you may have to repeat this Botox injection. After the second injection, you may have a relief of symptoms for almost 2 years, so the third injection may be much later. But some problems are dealing with patients who have voiding dysfunctions after Botox injection. You have a proportion of about 15% in highly specialized centers with high volume, and those will have to have drainage of the bladder. And in these cases, you either do the suprapubic catheter or something else, and managing those patients may be very time consuming. That's what you have to keep in mind. But actually, with the right indication, Botox injection is a very good option.
Thank you.
Okay. Are there further questions concerning urogynecology? If not, we would change to the next topic.
Thank you all.
Yes. Any questions to Professor Abu Nasr? Now, I want to thank Professor Abu Nasr because he was collecting a large number of patients of Gaucher disease. And he did a very hard job, really. It is an interesting paper he did. And I am asking, I know that it was a familial disease or racial disease common in Jews. I am asking about the present status, the prevalence in Egypt compared to the Jews.
Thank you, Professor Didi. Actually, I'm always saying to my patients that we are very similar to Jews because the Jews are a closed society. They marry from each other. The carrier rate is high. And we, like the Jews, we married from each other as consanguinity. But actually, the current status among the Jews, that the Jews have a very organized program for screening, mutational analysis screening for carriers. And they have limited the two important diseases, Tay-Sachs disease, which is very common among Jews, and also the Gaucher disease. Actually, they have a very great job among the mutation analysts. And I look always for the one who is dealing with in genetics, he should think of three lines of management. Actually, they are not contradictory. They should be complementary. First, the line of prenatal diagnosis. And also, we should consider among people who are fit for IVF or candidates for IVF, there is also PGD for many genetic diseases. And I think Dr. Yaoub, I met him before and I learned from him that his job about the prenatal diagnosis among genetic diseases, this is a very good line, but you couldn't pay for IVF just for PGD when you shouldn't. And also the other line is mutation analysis. Mutation analysis is for carrier screening. PGD for people candidates for IVF. Prenatal diagnosis have a wider indication. So these three lines, we should know them very well to choose what we should do for this particular couple. That's concerning the...
Dr. Ahmed.
Thank you, Dr. Professor Ahmed. And I want to a question about ultrasonic criteria of diagnosis of Gaucher disease. If the ultrasonic criteria is reliable, and what attracts me to go through investigation of a case, how to suspect that Gaucher is present in this lady attending the clinic, and if the third part, if there is any prospective study about the delivery of full-term baby or newly born clinical criteria if followed about the Gaucher.
Actually, as most of the inborn
Thank
errors
you.
of metabolism, they are different from other chromosomal abnormalities that could be diagnosed. For example, there's ultrasonographic criteria for Down syndrome or for trisomy 21, but not for the inborn errors of metabolism, because they are depending for the metabolism on the mother. So the disease does not show up during pregnancy. So it couldn't be diagnosed, and this is a big mistake among young doctors or doctors everywhere. They think, when they think about genetics, they think about 3D or amniocentesis. Both are wrong. 3D has no role in diagnosing inborn errors of metabolism.
How
and
to
also
suspect? How
so,
to suspect?
so there is no ultrasonographic criteria.
How to suspect?
Huh?
How to suspect it to go through?
How to suspect? Most of our patients actually, or unfortunately, they have one affected siblings, because and they pass through a tragedy or a drama to reach a diagnosis. And some of them, they don't reach this diagnosis in the first child, especially in other diseases that the child die very early, like metachromatic leukodystrophy, like Tay-Sachs disease, like Sandhoff disease. These children, they die before 3 years.
It's no
So
history. It's no
they
history.
are not diagnosed. So if they are diagnosed, and we have a proof diagnosis, enzymatic diagnosis of the affected SIB, we can go for prenatal diagnosis.
But
Without this, we can't.
Without history, nothing. You can't suspect.
No, we can't depend on
What
history,
about
because
يعني no cases have been followed till delivery and the newly born was
yes, many. All of our patients, we know about their delivery,
يعني الريت بتاع
and they are double checked. They are double checked when they because they are told when you have your delivery, come with the newborn to check it once more for the beta glucocerebrosidase.
Thank you.
As regards the three types of Gaucher disease, do you recommend the treatment for all varieties? Because type 2 acute neuropathic pattern, usually babies die early from 6 months to 2 years, and if this treatment is available here and people can afford the travel.
Actually, about the enzyme replacement therapy, enzyme replacement therapy is not effective among type 2 or among type 3 because they have neuronopathic symptoms, which is untreatable by enzyme replacement therapy. Enzyme replacement therapy started in Egypt about 15 years ago, but it was a donation from a certain company, and they couldn't increase the number of patients. And the problem with the enzyme replacement therapy that it is related to the weight. So when the child is bigger, is older, we should increase the enzyme replacement therapy. One vial of enzyme replacement therapy is about 10,000 Egyptian pounds. He needs 2 vials for the just newborns, 2.5 or 3 kilos. They need 2 vials each 2 weeks. I think now we are going to move to our next speaker. If you have any question to Professor Peter Malman, he was talking a wonderful book about the endometrial cancer, hyperplasia, and the indications of adjuvant therapy. Professor Malman.
Dear sir, I have a couple of questions. What is the maximum dose of gestations per day? Second question, what is the maximum duration of gestation therapy for judging if it's successful or not? What is the role of gestations in postmenopausal simple endometrial hyperplasia? Last question regarding the invasion of the myometrium during surgery to determine if we are going to do simple hysterectomy or radical hysterectomy. Do you depend on bisecting the uterus intraoperatively or with MRI preoperatively?
Very good questions. First, the role of the gestagens. The maximum duration of therapy is 3 months. Then you have to repeat the PNC. The usual dosage of MPA is 200 milligrams, or you use minestrol acetate 160 milligrams, but not longer than 3 months. Then you have lost the effect. In postmenopausal hyperplasia without any atrophic disorders, we don't need any treatment. You just have to control. You can perform a treatment with gestagens, but it's not urgently necessary. Hyperplasia without atropia don't need further therapy. You can try weight reduction or things like that. The diagnosis of the myometrial invasion preoperatively is very difficult. The best method is the ultrasound, but it's often false negative and false positive. So usually we open and cut the uterus after the hysterectomy, and we perform a macroscopic diagnosis. Sometimes we ask our pathologist to do it, but usually we control it just by view. If it seems to infiltrate more than the inner half, then we continue to perform the lymphadenectomy. If it seems to be less than the inner half, then we stop the operation, and the worst case scenario is that we have to perform another operation in the so-called two-step procedure. Did I answer all your questions?
Yes. Thank you.
Yes.
Yes, thank
Any
you.
other questions to Professor?
I mean, any question?
Thank you, Professor Peter. My question is about an office procedure in cases of thickened endometrium, where we can do endometrial aspiration plus CA-125. Is it any good?
Yes. Yes, you can really perform office procedures. You can try to go into the cavum uteri using PIPEL or other methods. You can just try to get some material from the cavum uteri, and following all studies, this is as good as performing a DNC. If you have the opportunity, you can combine it with the so-called office hysteroscopy. As you know, there are small instruments with 2 millimeters optics, and you can start with this procedure and then under control perform your sampling from the cavernary. And this is as good as a DNC.
Yes, Professor. Professor, yes.
As we know, the DNC is a blind procedure. And in the best hands, we can only curate 60% of the endometrial cavity. According to your lecture, a lot percentage of normal DNC. And this raises the importance of the false negative rate of DNC. What's the false negative in your study?
If you combine the DNC with a hysteroscopy, the false negative rate is less than 10%. Without hysteroscopy, it's between 30 and 40%. So the official recommendations is if the bleeding persists, as the clinical symptoms persist, you have to repeat the DNC, or you have to perform a hysterectomy if it is available, to exclude that you have a false negative result and you have not detected the endometrial cancer.
I may add to Dr. Peter, Professor Peter, that actually in Qasr Al Aini, most of us, they do hysteroscopically guided curettage as a routine. All these perimenopausal, postmenopausal patients, we do actually hysteroscopically guided endometrial sampling.
Yes. If it is available, it's really the gold standard to combine it with the hysteroscopy.
Please drop. I want to ask about if there is any beneficial values between the TUT and TVT.
I didn't understand. It was so long.
TVT and TUT.
It's not the professor. It's not a specialty. It's not a specialty.
I'm the one of the endometrial disorders. Excuse me.
Hisham, Dr. Hisham.
After the session, you can ask Ralph. Dr. Ralph is just behind you. You can ask Dr. Ralph after the session. Hisham.
My question, please. My name is Hisham Haggag. It's regarding pathological surprise if we discovered that the myometrial invasion is more than 50% after a hysterectomy, a simple hysterectomy maybe, or even a panhysterectomy. Is there any further recommended management? This is my first question. My second question, during hysteroscopy, do you believe that peritoneal cytology could be positive during staging for endometrial cancer, and would this affect the prognosis?
I start with the second question. We had a long discussion about the sense of peritoneal cytology because nearly all women undergoing a hysteroscopy have a positive peritoneal cytology. First argument. Second, following all studies, there is confirmed that there's no prognostic effect of positive peritoneal cytology. So patients having this positive result have not a worse prognosis compared to those who don't have it. So there's no urgent need to perform the peritoneal cytology. Unfortunately, it's very common, and in the international guidelines, and we have to be comparable with the international guidelines, it's still inside, and therefore we have decided to continue with this method, although it makes no sense. Concerning the first question, the intraoperative quick section, if it is available, is the most sensitive method to detect the infiltration rate of the myometrium. There's no preoperative method to determine it really with a high sensitivity, so you have a high risk of a two-time operation, so that you have to wait for the final result of the pathologic examination, and then in worst case you have to repeat, you have to do the next operation.
How long should we wait before repeating the second operation?
We do it immediately or after 6 weeks. There are a few studies who have examined this question, and we do it, if it is possible, in an interval of 10 days, 5 to 14 days after the first operation, or we do it after 6 weeks.
Thank
and
you very
if
much.
possible by laparoscopy.
Yes, Professor, my question is if you have a patient who is virgin and postmenopausal without bleeding, she had thick endometrium 9 millimeter, and she was given Zestagen cyclic, and she has withdrawal bleeding few days. What do you think? She is refusing hysterectomy.
Yes, we discussed this question, what to do with a ultrasound suspicious endometrium, and we came to the result that the data confirm that the sensitivity of the ultrasound for the detection of endometrial cancer is so low that the diagnosis suspicious endometrium is not sufficient to perform a hysterectomy or anything else. Though in this case of a virgin, we would wait for on the clinical result of the clinical symptom of a bleeding, or if this endometrium is growing, so the size after control maybe 3 months is growing, then we would recommend to perform a hysterectomy.
Thank you very much. I think now we have a wonderful talk by Dr. Yaoub Khalaf. If you have any questions to Dr. Yaoub Khalaf about commercialization of IVF. So I may ask Dr. Yaoub, because I was interested in your talk, could you give us an idea about the British guidelines, the British guidelines concerning the how to listen this commercialization of IVF?
I think we are fortunate in the UK that we have the Human Fertilization and Embryology Authority, and they are always looking at way of better informing patients. So they are now thinking of a scoring system for particular clinics. You know, some of us use TripAdvisor to choose a hotel, to choose a travel agent. The Human Fertilization and Embryology Authority is creating a score for clinical success, credible information, good practice, safe practice. Then the patient will be informed as to which clinic they choose. And that will hopefully weed out the outrageous business. Yes, yes.
And it's
Yeah.
not growing the endometriosis. In the follow-up.
Okay.
Yes, I would just do follow-up.
I'm sorry, Dr. Abbas, I wanted to ask about a case in front of me. The patient is very related to gynecology.
We have now questions for Dr. Yaoub Khalaf concerning the IVF and the commercialization.
I'm sorry.
That's quite difficult. But if she has no bleeding disorder, only the cycle.
I can't hear you. Sorry.
I'm informed that I have to discuss it with the patient what she wants.
The PGS, is it useful or not?
Sorry, what is
The PGS. You
Fish.
say it's something commercialization or something it's useless.
You're talking about fluorescent in situ hybridization.
No,
Fish.
the pre-genetic screening.
Pre-implantation genetic screening.
Genetic, yes.
Yes, I think I have mentioned a couple of slides on that. Pre-implantation genetic screening using fish for day 3 embryos should never be performed. Never.
This is useless?
Because it does harm the patient, not just useless.
Yes, but
Okay.
we said that the PGT is